And some new faces. So this evening we are incorporating a Dementia Live Simulation. So basically what we're going to do is kind of divide the group into half. And half of you are going to hang out with me for the first session, and we're going to really dig into and talk about understanding common behaviors when it comes to dementia and how we can best respond to those behaviors. While the other half of you go with my friend Judy, who's in the back. She is with Hospice of Southwest Ohio, and she's going to be leading you on a Dementia Live Simulation. And this is meant to be an experience that helps to give you a direct experience and empathy to understand what it's like to have your processing and your senses altered by dementia. So it's going to give you a really direct way to kind of understand what someone might be going through. So when you head back with Judy, she's going to give you the opportunity, if you kind of want to observe and you don't want to tell us in front of the whole room, but maybe you just kind of want to sit back and watch and not participate, that's okay too. But for now, we are going to divide up half and half. So I'm going to ask that this part of the room go ahead and join Judy in the back, and we're going to take you out into the hallway and close the doors, and she's going to get you ready for that simulation.
Thank you.
You'll come back in about 25 minutes, and you get to hang out with me.
Yeah.
You're welcome to leave your belongings here, whatever is more comfortable for you. I'll make sure Chris keeps an eye on it.
Perfect.
Chris, you call Amberley if you have a problem. Which side of the Amberley house do you call? Police or the admin?
You're going to follow me back here.
Police.
You are going to need 2 hands for this.
You're on the phone.
We're going to close the door so she can talk and we can talk freely as well. Yes.
I'm going to wait for those doors to close so that you don't hear any secrets. It's best to go into that simulation kind of not knowing exactly what to expect. It creates a really whole experience for you. Okay, so they're getting ready to close those doors, and I'm just going to do a quick recap on what we've talked about in our previous 3 sessions, okay? So tonight we're going to be talking about behaviors. I think when we met first in, gosh, when was that, March? We talked about healthy living. We talked about a lot of those lifestyle choices and decisions we can make to help reduce our risk of developing dementia. Then when we met again, we talked about the warning signs. As I age, what do I look out for in myself or my neighbor or my loved one? You know, what are common signs of dementia? And then what are those typical age-related changes that just happen as we get older? You know, our brains slow down as we age just like our bodies do. And then we talked about communication. So what you're going to hear tonight is probably a little bit of familiar information from what we covered when we talked about communication. Communication and behaviors really go hand in hand. So before, we talked about things like joining someone in their reality. Someone with dementia, you should join them in their reality because they cannot join you in yours. You know, they do not have the logic the way that a healthy, normal brain does to kind of follow any kind of clues and cues to ground them in the here and now. So we want to kind of join them where they are. We want to avoid arguing or quizzing or testing someone. That will likely lead to probably not a great interaction. I know I don't like to be told like, you're wrong, right? No one loves that. So it might make someone kind of shut down. Same goes with someone with dementia. So we might see that lead to some behaviors that are related to that communication, right? We want to be really careful with not just our verbal communication, our tone of voice, our facial expressions, our body language. So I think when I stood up here last, I was standing up here and I was just telling you how excited I am to be here, right? And I was being sarcastic, crossing my arms. And so all the words coming out of my mouth sound like I'm saying I'm excited to be here, but communication comes in a lot of different forms, right? So someone, as they progress in the later stages of dementia, middle to late stages, they're losing their ability to communicate their needs with verbal communication. So part of the way they're going to be communicating is through their behaviors. So we might at times find so-and-so was always sweet as pie, and I just saw her get so aggressive. Or I heard words come out of her mouth that she never said before. Some spicier, flavorful language, right? So we're seeing these behaviors as a form of communication. When someone is trying to tell you, I'm uncomfortable, I'm frustrated, I'm confused, and they can't tell you with their words. So just like we talked about with communication, we really want to focus on keeping someone safe and happy. So we can employ different strategies, just like we talked about last time, about, kind of following them and meeting them where they are in their world, focusing on the feelings over the facts, and making sure that we are creating a soothing, calming environment and making them feel seen and heard with whatever emotion they're feeling. And then we can kind of move along, maybe tell a therapeutic fib and go along with where they are, and then we can move on to an activity that they enjoy. So let's get into today. So what we're going to cover in the next 20-ish minutes is really talking about some of those common triggers that we see oftentimes for behaviors that are associated with dementia. So we're going to talk about the process of how, no matter what type of common, dementia-related behavior we see, we can use a process for kind of assessing, evaluating, and identifying some of those challenging behaviors. And then again, just like we did with communication, talk about those strategies that we can use to address those behaviors. So I think we talked last time about putting on our detective hat and kind of using what we're seeing in our environment, what they might be trying to tell us with, all these different forms of communication to address what might be happening. So we'll continue and expand on that this evening. So behavioral changes can have a lot of different types of triggers, right? So even in a healthy, normal brain, this is the case, right? If we're in pain or we're uncomfortable, maybe we're overstimulated. Someone with dementia, and this is something that you're going to experience this evening in terms of processing. There is some gear that'll help you understand what it might feel like to process many things at a time in your mind. So overstimulation can be a piece. If, let's say, someone with dementia comes into a room with 20 people all talking at once, they have a hard time following a conversation with one person. So that's going to be way too much for them to follow, and they're going to feel overstimulated. Or maybe they're bored. Sitting in front of the TV watching Jeopardy is not going to be a fun activity for anyone if that's all they're doing. And that's including someone with dementia. So having dementia does not mean that we don't need to be continuously stimulated. We want to make sure that they have engaging activities that they can participate into in a safe way. Any person wants to have some meaning and purpose in their life, right? Even if they have dementia. So that might mean, if they always did all the laundry, they always took care of the household, maybe that means they're helping fold towels, right? Let's do something that can give them a meaningful activity, even if they're not going to do it the way you want it done, even if you're going to have to refold those towels later, right? We want to give them something that's going to help stimulate them and find that balance. We can also be fearful or frustrated, so attempting to communicate and not feeling like someone is receiving or understanding, or being in an environment that can be disorienting or confusing for you can lead to some of that fear. Unfamiliar surroundings. It gets more challenging for an individual with dementia to leave the house. That's more than likely going to be the final kind of comfort zone that they have. So when you take them out of that familiar space where they have some understanding of where things are and they have a little bit of routine, it's going to be much harder for them to kind of regulate and process what's going on around them. And then complicated tasks that can be really disorienting and cause some behaviors as well. So when I say complicated tasks, I don't mean changing the oil in your car. I guess maybe I could do that, maybe. We're talking about things that are like brushing your teeth. If you were to have an alien come down from space and you had to explain the process of brushing your teeth, it's a really complicated step-by-step process too. You could write down all the directions for brushing your teeth and it would probably be a few pages. So it's not as intuitive as it seems. It's just something that we got used to because we do it all the time. But all of that information over time is deteriorating for someone with dementia. So even a simple task that we would assume is simple, like brushing our teeth, can become complicated. So when we're looking at understanding and addressing the behavior at hand, no matter what the trigger was, here's kind of the line of thinking that you want to employ. So we want to detect and connect. So, what are we noticing in our environment? What are they maybe trying to tell us about, the environment, or what might be irritating or agitating them? Am I noticing that they're kind of tugging at maybe a sweater, or are they kind of itching at their neck? Maybe I'm going to check the thermostat, right? How is the room stuffy? Could I open a window? Is there a fan I can turn on? So we're going to kind of try our best to detect and connect with what's going on. address their physical needs first. So I mentioned that safe and happy, right? Safe is first. So we want to make sure, are they in any kind of danger? Are they in any kind of immediate physical pain that we need to address? Do they need medical attention, right? So if that's not the case, then we're going to move on and kind of assess their emotional needs. So what might they be trying to tell me by, their agitation or their irritability, or maybe they're angrier than they normally would be in this scenario? What else might be going on? Is it something where I'm trying to help them put their shoes on, I'm noticing them wincing in pain? Maybe they have an ingrown toenail that they can't tell me about, right? So try and use what you're seeing, and when I do this, I'm noticing this, and try and figure out what might be going on behind the scenes. And then when you do notice that trigger that causes that behavior, it's not the end of the world. It doesn't mean you're a terrible person, it doesn't mean you're a bad caregiver. It might just mean you learned some new information. That might change over time. Sometimes someone might love Elvis, and then they get to the point where they get to a stage in this disease and they hate Elvis. They despise the sound of Elvis. If you turn on Elvis, so help you, like they are going to throw a fit, and they might throw some things. So, okay, we no longer like Elvis. During my next visit, I am not going to turn on some Elvis, right? So you can really use what might even feel like a hard situation and figure out how you can adjust for next time. Okay, I think I got a little ahead of myself for the sake of time. So this just goes into a little bit more details on that detect and connect. Again, we're joining them in their reality. We're trying our best to see the world through their eyes. So in doing that, before we intervene, we're thinking about all the who, why, where, how, what's taking place, what took place before we saw this behavior, and then kind of what's going on after. And then make sure that, we talked with communication about that approach. So we want to make sure we are approaching calmly. Someone, even in a state of, any kind of heightened emotion, if you're being calm, they're going to start to over time match your tone. So you want to be a calm, helpful person. And come back to those communication strategies we talked about. You want to approach from the front, you want to make eye contact, and you want to be at eye level. So I don't want to pick on anyone, but with all of you in a chair, if I'm approaching you from the front, but I'm not making eye contact, and I don't have your direct line of sight, I want to be on your level. If I'm up above someone with dementia, let's say I stand in front of your TV show, right? That person with dementia might just see me as an obstruction. They might not think, oh, this person's trying to talk with me and I should look up and make eye contact. They might just say, they're blocking my show, and move their head around you. So you want to make sure that you're on their eye level, that you're approaching calmly and slowly and getting their attention, so that you don't startle them and then have a negative reaction when they're afraid. So addressing their physical needs, we're talking about those medical issues. Maybe they're hungry or thirsty. I know I am, just generally speaking, a hangry person. So I am constantly trying to say, like, okay, I'm feeling a little cranky, I'm feeling a little off. Have I had some water? Do I need a snack? Same goes for here. Let's think about those, immediate basic needs. Lack of social interaction. Maybe it's too little or too much. And then kind of look for some of those environmental triggers too. Maybe the sun's shining and it's too bright and it's distracting them from the thing that you're trying to tell them. Or maybe the music is too loud while they're trying to eat and they can't focus on both at once. Yeah?
I guess I'm having a problem with what you're saying.
Mm-hmm. Yeah, tell me more.
What you're saying is not good. It is absolutely not what I think. I'm in agreement with you. Being an educator,
Yeah.
all the students that I met, college students, young students, they don't have clue. They don't have even the knowledge of if an old man want to drink or it's cold or it's hungry or wants to. It isn't there.
Yeah, it's really hard. So
It isn't there.
yeah.
And all things that goes right now, as a grown up to do for other people, that has to be at the beginning. Because all our kids are known to look at the.
Yeah, where the kid, I feel like the younger people probably, I remember being 20 and being reckless and thinking I was gonna live forever. I ate whatever, I drank whatever, we'll leave it at that, right? I'm not gonna say anything else.
But it isn't
You're a
that-
little more reckless. You think you'll never be older, right? And so this is something that we see is happening later in life. They don't need to worry about it. When it affects them is when it's their grandparents, their family members, their loved ones. So this is an increasing problem that's gonna affect people. And I know when I was in my 20s, my grandpa was living with Alzheimer's, and I got really fearful. I didn't know how to interact with him when I visited, and I didn't have any tools to know, okay, what do I do if he says something, or what do I do if I show up and he doesn't know who I am? I can still have a meaningful visit with him, even if he doesn't know my name. Who cares? But at 20, I did not know that. So I think like we gotta increase that education for everybody.
On the lower level, not just
Yeah.
country.
Absolutely, yeah, give them my number if you meet any of those young folks, I'm happy to talk to them. We go through, so Judy, you'll meet Judy, we train all the students at Butler Tech up in Westchester in rotations every fall. Before any of those kids graduate from that school, those young people, they have all had some dementia education. So we are working on it.
Even the caregivers that come to help you,
Yeah.
they have
Kids.
no clue for it.
Yeah, and we do staff trainings too. So we are, you know, if you know of organizations or people that need resources, give them my information. Because we are trying to bridge that gap. Because we know that's real. So thank you for bringing that up. Okay, I'm gonna move us forward to thinking about those emotional needs. So we talked about focusing on the feelings over the facts. I'm gonna say that over and over again. Use what you know about that person's preferences. So this can help with different types of interventions when they are in that heightened state. So if you know that they love the smell of lavender, they were always an avid gardener, maybe we're incorporating the scent of lavender into that room when we visit. Is it in the form of, you know, some Febreze fabric refresher or whatever? Or are we lighting some candles? How can we kind of help to set that tone? Maybe they really love baking, you know, so can I get them out of this heightened state and then kind of deflect and move our conversation to an activity that they enjoy? You know, even who cares what the cookies look like, maybe we're just mushing some dough around, but how can we kind of move them to a more soothing activity that they enjoy? Do they love walking in nature? Do they love looking at the birds, right? How can we incorporate some things we know that they like to help bring them back to that less heightened state? And then again, you're not going to get it right every single time. When I look back at when I was 20 years old visiting my grandpa, I know I did it wrong. I know I, you know, asked him if he remembered me, right? So you want to make sure that you're going back to what you've talked about and what did I notice? What didn't work? What did work? What should I avoid doing next time? What did I notice and how can the room is always stuffy. That room where I visit him is always stuffy. I'm going to arrive 10 minutes earlier and I'm going to see if we can open some windows. Or maybe I'm going to bring one of those little clip-on fans that can sit on the side of the table that can blow and circulate some air. Or bring him a really cold drink that he loves, right? So how can we make this better next time? What went well, what didn't, and how can I make those adjustments?
But look, at the 20s, I think it's a bit too late.
You think it'll be too late?
Yeah, I'm
Sure.
not going to find. Well, I'm growing up at 7, 8, grandparents lived around. and
Yeah.
We didn't need to be asked.
Mm-hmm.
It was there.
Yeah, yeah.
Automatically it was there. We didn't have to be told it was there. I'm sure sometimes we looked too.
Yeah.
But it was there and we were aware of it.
Sure.
And that's what we like.
I think having
As
those
a society.
generations together can make a huge difference. So I hope we kind of swing back in that direction, right? Yeah, yeah. Okay, so when we think about, we're going to kind of move through some specific behaviors very quickly for the last few minutes, just so you can get an idea of what these look like. We're talking about anxiety or agitation. These are some of our common behaviors. So when we're talking about this, we're looking at someone who's maybe experiencing restlessness or pacing, distress, and over-reliance on caregivers. So this can kind of come in the form, if you're familiar with sundowning, maybe someone who people do get pretty restless and start to pace at specific times of day. We want to think, again, use what we know about this person. What did they used to do at 5 p.m. every day? Maybe they're at the window waiting for so-and-so to get home from work, right? Or waiting for the kids to get off the bus. So use what you know about the individual and their life and their history to kind of have a little bit more understanding of where they are and what might be going on that could be causing that anxiety or causing that pacing. They might just be kind of stuck in a different time and place. Confusion or suspicion, not recognizing familiar people, places, or things. This can show up in the form of accusing others of theft, infidelity, and other scenarios. So we often see that, we might lose track of things that we've donated, right? I gave that tea set away 6 months ago, but now I'm looking for that tea set, and what happened to that tea set, right? So this can get kind of common. And again, we're not looking to argue or logic our way through a conversation with someone who's in this state of confusion or suspicion. We want to make sure that we're hearing them out. You're right, I can't believe that tea set's gone. That's really, really frustrating. I'm going to help you look for it. I'm going to spend the next time, I'm going to go down in the basement. Why don't you make yourself a cup of tea? I'm going to go down in the basement and look around for that tea set. Just let them feel validated and that they're going to move along. You're going to move into a different activity, and they're going to stop fixating on that tea set, right? We just got to kind of move them out of that state and make sure that we're not you gave that tea set away. You don't even remember giving it away. That's probably going to make them feel that they're not being heard, right? And they might be kind of offended that you don't believe them and that you're not siding with them, right? So we want to make sure that we're kind of going along with what they're feeling. Aggression, aggressive behavior. This can look like physical aggression or verbal aggression. So it can appear out of what feels like no reason whatsoever. What brought this on? Or it can come following a trigger. It kind of depends on the person. But again, we want to kind of use what were some of those triggers that we may have seen. Or sometimes it can appear as, the paid caregiver that came in the room to help give them a bath looks like someone they went to high school with that they hate, right? It can be just as simple as that. So how can we work to diffuse that situation? How can we maybe step out and let that person take a breath and come back in and try again? So again, we want to kind of try and identify what we might be seeing and why. So oftentimes aggression specifically is not dangerous, but it can be really scary and a little stressful. Occasionally the person can be a danger to themselves or another person. We might need to take some safety measures. It depends on the person. We want to make sure that before we're deciding a more aggressive intervention here that we're talking with their doctor, or calling your safety officer, calling 911 and getting some help, calling our helpline and getting some help. With repetition, we're talking about someone saying something over and over again, repeating words, maybe asking the same question over and over again, right? We talked about that with communication. So this is something that we see often. You can honestly use it as an opportunity to try again. If you feel like you didn't, respond properly last time, well, they're probably going to come back in 10 minutes and say the same story. So there's always that opportunity to kind of figure out how you want to, improv. You might be having a little bit of a one-sided conversation. But again, we just want to make sure that they feel heard. And then what I really want to note with wandering, because I think with a lot of these behaviors, we see them most often in the middle to later stages of the disease, further along in the progression. Wandering can happen in the earlier stages as well. And this can be really scary, because if we think about someone getting lost, they can be behind the wheel of a car, they can be on foot out in the heat or on a really busy road, and they might think that, I'm a little turned around and I think I'm just going to go this way. And then they get more disoriented, and they're kind of digging a little deeper. So I wanted to note that this can happen at any stage in the disease without any kind of warning. So it might not be that you're noticing someone, walk out of the house in the middle of the night who's in those more advanced stages. This could be someone who is in those early stages, maybe just showing some of those early warning signs we talked about. But we do know that 60% of people with dementia will wander at some point. So this is something we want to be aware of and kind of be planning what will we do, what kind of safety measures can we employ to combat wandering, when or how that happens. So I think Judy is probably wrapping up, right? Okay, I talked so much, I cannot believe I did that in that amount of time. I know that was really quick. Does anyone have any questions before we kind of rotate out?
Very nice. What if you're an old person and then someone did take something away? sure they don't
Mm-hmm.
believe you because they see you don't know what you're talking about.
Yeah, I mean, I think that might be just kind of a different scenario entirely, right?
That's pretty smart.
Yeah, we want to make sure that, you know, Mason was talking before about how people with dementia can be especially susceptible. So we want to make sure we're on the lookout for them. How can we, you know, if they do have precious belongings that we do worry, we want to make sure they feel reassured that they're safe. Okay, how can we make sure that those items are secure? You know, we can kind of mitigate that a little bit. Yeah.
Say anybody that's ever been around a person with dementia, everything you've said here tonight is exactly true.
Yeah. Well, thank you for pointing that out. Yeah.
Every step by step.
Yeah. And you know what's really hard is that it can look so different in so many people. You know, those behaviors can look different. So there's no perfect roadmap. So having some examples and talking about it more openly will give people a little bit more guidance on what you can do. So thank you for saying that.